Right. So look, what I'm going to talk about now in the next hour is what ADHD is, when in clinic you should start thinking about it, and when you should kind of cast your minds elsewhere. What the sort of things you need to know to make a diagnosis, and how you kind of gather things together, and what the sort of treatment options, or rather how you approach treatment. And I wonder if I should change that, because actually treatment may not be the right word. So what is ADHD? I've got a couple of analogies to share with you, but I think it's best to start from a kind of understanding of what exactly is going on. So I want to draw a distinction really between yourself. Yourself is the kind of abstraction of whatever neurology is going on into your experience of a person, of an identity over time that makes plans, that has priorities, that understands things, understands rules, understands expectations. So it's that kind of side of your identity, and your brain, the kind of more automatic and less conscious aspects of your brain. And in a way, what ADHD is a divorce between the two. It's a reduction in the amount of control that your conscious and rational self has over the kind of brain underneath it. And the nature of the brain underneath it is that you therefore end up having less control over emotions, desires, impulses, and also your brain's very kind of hungry for stimulation, because that's what it's for. So I just wondered if people could pop in the chat how that would, if you woke up tomorrow morning and suddenly you had very much less control over that underlying kind of seething mass of stuff that's going on in your brain. How would that affect you? What might you find difficult? And it's worth remembering that this isn't just your own impulses or your own thoughts. It's also sensory input. It's also emotions. It's that whole kind of filtering and making sense of function of yourself. What effect would that have on you if you lost it overnight? Everyone's gone very quiet. Yeah, so focusing for long periods, in fact, focusing for any sort of period requires you to shut out external stimuli. So for instance, my dog growling in the background. Maintaining relationships is important, and because again, relationships are a long-term project. You need to kind of spend a lot of time suppressing your impulses to keep going. And not sitting still is interesting, because it's partly a lack of stimulation, but it's also the fact that movement itself is stimulating to this autonomous brain that's doing its own thing. Yeah, I very much might walk in the road, Joe. That's very true. And you also make the point that it would be very scary and overwhelming. And I think that's a really good point to take back. Is that having ADHD is scary and overwhelming, even though these are not necessarily children who are presenting in a scared and overwhelmed way. So I think that is a really important point. So then the next question is, what would people notice about you? Let's say you were to a conventional lecture, an in-person lecture, or you were with your families or out in public. What sort of words would people start to use to describe you? Yeah, fidgety. Yeah. Yeah, they would be disruptive, and sometimes that's a good thing, but obviously that's not necessarily what people want from you at particular times, particularly if you're in a relatively professional position. Goes for 101 to 160 is a very precise, very precise figure that you go for. Yes, you go from 1 to 160 in no time at all. And I'm glad that someone's come up with annoying, because that is something that is almost always something that's said about kids with ADHD, that they are annoying. So you can see how already, just from a very simple thought experiment around losing control of your underlying brain focus, your underlying subconscious brain functions, you can already deduce and guess at quite a lot of the features of ADHD already. And so I think, obviously this isn't kind of all or nothing. These kids and adults have a reduced control over their underlying brain function, but it's not none, and it is a spectrum. So some have a very mild difference from the typical population, and others have a really marked difference. So a way to explain this to people, and a way to explain this to kind of peer people, or to children, or to parents, is I sometimes like to talk about the hungry brain. So it isn't that everyone's brain isn't hungry, it's just that most of us can keep it under control. And what the brain hungers for is information, stimulation, emotion, movement, but anything basically that feeds it, and stimulation of stimuli of all kinds will do it. One of the insights that I think is really important that this explains is the fact that very often children with ADHD are entirely still and extremely good at concentrating when they're playing video games, because they are very stimulating. They're constantly feeding on kind of every few seconds. You get a new bit of stimulation, you get a new thing, a new something or other. And so I think that explains quite neatly why there is this real paradox, if you think of it in some ways, that a child who is never still otherwise can be stock still playing Fortnite for hours on end. It's to do with this deficit of stimulation that they suffer for most of the time. And the other thing about this hungry brain is that it's not easily satisfied with the same thing over and over again. And there's a real need for new stimuli and for new things that at a very basic brain level. And so that explains distractibility, I think, and explains some sort of difficulties.
Someone's dog. Someone's dog.
Yeah. Is that Max Davies? I think it is. Who's doing the talk? Looks like.
Sorry, dog barking. So the stimuli, the same stimuli becomes very quickly less stimulating and satisfied over time. Which is the other type I've used recently to explain this is the T-Rex brain. So it's quite appealing for, and I did a little video which I'm sure you can look up online. Really, essentially, the stormtrooper in this image is yourself, your kind of sense of self. And I don't know why, maybe I'm projecting something that I was a stormtrooper in my case. And the T-Rex, and in this case not a T-Rex, but there is later in the video a T-Rex. The dinosaur that you're riding around is a T-Rex, a very hungry and kind of aggressive, often aggressive dinosaur. Whereas other people have perfectly kind of sedate normal brains like this Stegosaurus. So that's a nice kind of image that children can take away of them having just a different brain that they have to ride around on, and sometimes it's quite tricky to keep on top of the brain. So that all said, you have, I think, an idea of what is different about these brains or these people from that very simple image and that very simple analogy. Does anyone not understand that? Does anyone feel that there's something about that they can't quite take in? Because otherwise I'm going to move on. I'm just being told to close other things that might. If you're in clinic and you're seeing a child who has been referred for whatever reason, at what point should you start to think about ADHD? And I think I'm going to start with the sorts of things that I'm going to start with the sort of things that are not terribly useful. Please let me know if there's any technical difficulty. I'm getting red flags about my internet connection. It's just that's fine. So the less useful, frankly, symptoms are, and this sort of always is a bit of a red flag for me when people refer with behaviour. And also if people say, well, you know, his problems are behavioural, as if that explains everything. It's like saying somebody who comes in with a cough has a cough-related problem. Doesn't really, it's strictly correct, but it doesn't really tell you anything at all. And so whenever you say that there's a behaviour problem, and it doesn't, well, the first question is, well, what is the behaviour? What is the behaviour that you want to change? What is the behaviour that is unwelcome to you? And that's the first thing. The second thing that's not terribly helpful and not terribly specific is tantrums or losing their temper and lashing out. That's very non-specific and is probably more common in children with ADHD, but certainly isn't a clue to lead you in that direction. Again, you can call it oppositional defiance, and the psychiatrist would give it a diagnosis, but it's a pattern of behaviour, isn't it? It's not doing as you're told. Again, more common in children with ADHD, but not by no means specific to this group. And if you're sifting through all of the children who don't do as they're told, you need other indicators to suggest that they might be the group who have an underlying ADHD difficulty. And equally fighting aggression. There's a lot of kids with ADHD and also aggressive behaviour, but there's a lot of kids with ADHD who are not at all aggressive, who've never been in a fight in their life and never heard a fly. So there's a huge amount of variability there, and the fighting and the aggression does not come from the ADHD. It's very important to say. If you have a child who's just got problems with academic difficulties and who doesn't have any difficulties outside of the academic realm, that is not ADHD. It may be that you need to dig a little bit into everyday life to work out what exactly is going on. But if it is just an academic problem, so schools who kind of want to refer somebody who's only really having difficulties academically for ADHD, that's probably not the right approach. Poor friendships is something that's actually very, very common in ADHD, and I almost put this in for the converse reason, in that although often it's thought that poor friendships is not due to the ADHD, and a lot of kids with ADHD are then investigated for autism on the basis of the fact that they don't have good social relationships, and that's actually not always necessary, because ADHD on its own, as you've already said in a sense when you answered my question, ADHD on its own can very easily impair your social relationships and your ability to at least maintain friendships. Very often they can make friends relatively quickly, but it's maintaining those relationships which is quite difficult for them. So essentially, any symptom which is confined to one context or one relationship is unlikely to be attributable to ADHD. Now, That's not to say that they can't present very differently in school and at home, but if there are literally no problems at all, even if you've kind of dug into it in one of those contexts, then this is probably not somebody who has any sort of neurodevelopmental problems. Now, having said that, although I want there to be some difficulties across both all contexts, what I think is most helpful in terms of the history taking is to be specific about what happens in particular situations, because I think the main reason for that is it strips away some of the value judgments of, you know, he's defiant, he's bad, he's this, he's that, and it brings it down to a more descriptive level. And so those of you who've worked with me before will know that I'm slightly obsessed with these particular aspects of history taking. So the morning routine. Now, the morning routine is generally useful to ask about, you know, obviously you'll have defined behaviours, you'll have children with autism who are very kind of set on routines, or who kind of, you know, have meltdowns if particular things wrong. But also within ADHD, you'll get kids who are, you know, perfectly willing but extremely distractible, and you sort of find them in their pants watching TV when you've left them with their clothes, or they've no idea what day of the week it is, and they just wander out of the house without anything really that they need. So then of course in the morning routine it's always very useful to talk about how you get to school and the experience of that. And so you've got things like running in the road, you've got behaviour in buses and trains that can be quite challenging. And so the whole experience of getting them from bed into school is often very revealing and very interesting. And then once they finish school, what they do when they come out, I always like asking about this, have they forgotten stuff? And often you have families kind of listing and reeling off the amount of stuff that the children have lost. And you just kind of got to have a feel for how much of that is unusual and how much of that is just difficult for the age. And then of course, you know, are they running off? Are they kind of chattering away and, you know, very, very kind of want to tell you everything that's been going on? Or are they very silent and quiet on the way home? Going to the supermarket is often a real moment in the history taking. I would like to have at some point a kind of grading scale of parents' facial expression when you ask them about going to Asda, because often it's just a complete nightmare. And I think that's really important, but it's not just it's a complete nightmare. You have to ask, well, what is it that they do? So you know, children who are kind of oppositional and kind of don't have a good relationship with parents will often use it as an opportunity to have a fight about something and, you know, kind of argue about something. And children with ADHD will often sort of rush off, use the kind of wide open spaces of the supermarket aisle as the most wonderful runway, and also will kind of grab things and put them in the trolley kind of impulsively. And the queuing at the end of supermarkets, which, you know, for a few months ago I was saying, well, there isn't much queuing anymore, but there really is now. That can be very, 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 very hard for them to deal with. So it's a description of what happens when you take them to the supermarket that's really, really helpful. Mealtimes are really helpful as well. And that's really about sitting still. And even those that will sit still, it's important to ask, you know, okay, did he sit still and then immediately as he finished his food, he's off? Or did he sit still, but only if the television's on? Those are the sorts of things that are really important. And then bedtime. So I think probably most of us know that children with ADHD find it difficult to settle to sleep at night. But again, that's not the same as not wanting to go to bed, or, you know, using bedtime as another opportunity for a fight. So the slightly different pattern is often a child who will go quite happily, but will come out with a variety of different excuses as to why they've come out. So, you know, they want water, they want to wee, they want, you know, all sorts of things, or they've seen something or whatever. And often, sometimes they're kind of presenting with, and, you know, looks like an anxiety problem, but really it's the fact that they can't settle at all well. It's also useful to talk a little bit before the very going to bed, that kind of routine stuff. You know, can they remember that they have to brush their teeth, or do they kind of get distracted by stuff? And if they are brushing their teeth, do they do it for long enough? Those little mundane things, little details that cut through the fact that the parent is just exasperated, because the parent who's exasperated with this child will just give you a yes answer to any behavioural question, and it won't help you. I think it's really important to get descriptive instances of everyday mundane things and how they go, because then you will start to get the pattern of this child being the kind of T-Rex brain child or not, being something else. So that's what we train people to do in the initial assessment in Lambeth, where I work. When you see them and they look like they might have sort of ADHD picture, and there's a few other things that you can also ask about. I like to ask them about going to the hairdressers or the barbers, and how absolutely exasperated the barbers get with them. And that's another really interesting sort of external person who has a very specific task for them, which is sitting still, and how much difficulty they have with that, and what strategies the family need to manage. And you know, obviously there's a few other situations where sitting still and concentrating are important, and some of them will just come up in conversation generally. I think it's very important to not just always have a checklist, because it makes assessments boring and you miss stuff. It's chatting about the family's actual life with a little bit of structure like I've given you is much more useful in finding out what's actually going on than any kind of checklist. I'm a bit wary of them. Nonetheless, they are very efficient in establishing somebody's opinion about roughly where this child is on the kind of spectrum between typical and completely wild that exists in ADHD. So Connors questionnaires, strengths and difficulties questionnaires, they're all fine. I mean, we use Connors a lot because I think it's got some nice features around looking at other aspects of the child, like their social abilities, their learning abilities. I think they're quite good, and they have got kind of automated scoring as well, which is quite helpful. But really, it's a alternative to a proper interview. My feeling is that if you've done a proper interview with a parent and the parent made sense and had a consistent history, I don't think there's any need to do a parental questionnaire, and that's my personal view. Because I think I think you've already got the information in front of you, and the problem, we get a bit fixated with the scores in medicine, don't we? We like scores, and it's only in this case a questionnaire score is just someone's opinion turned into a number. It's nothing more than that. So that's the kind of scores. And conventionally, oh, by the way, if anyone has any questions, just pop them in the chat. I will pause again in a minute. Conventionally, people have used a kind of score of more than 2 standard deviations above the mean to indicate clinical significance. That, you must remember that that is arbitrary, and that actually what the point you've got to look for is whether impairment is being caused by the features that you've identified. The other thing that you need to think about is whether the features that you have identified are also contributed to by other features. So I don't think, I mean, I never would want anyone to be referred from primary care or from schools for an ADHD assessment, equally not for an autism assessment. What we need to do is develop mental assessments which assess the whole child, not only in fact in terms of their current profile, but also in terms of the context. So while I don't think that you can necessarily get ADHD from having anxiety, if you have a bit of ADHD, not too much, maybe not diagnosable, and you're also anxious, that will make things a lot harder for you and often make your ADHD diagnosable, if that makes sense. Equally, previous trauma will often make you more hypervigilant, but that is different to ADHD. They are more kind of wary than the ADHD kids who are kind of just sort of out there socially. And I think also trauma also has a very specific, often has a very specific effect on particular relationships, so particularly with parental relationships. So all of this stuff is really important in explaining why the child struggles in particular contexts. None of it necessarily will put you off diagnosis, which you can just, just look at the symptoms and see if you can pin everyday impairment to the child's hungry brain. Are we okay so far? Okay. So there is always this question, and whenever I teach on ADHD, someone in the coffee break will always say, well, we're all a bit ADHD or we're all a bit autistic. And that's trivially true, but also unhelpful and annoying. It is on a spectrum, as I've said a few times, which is a normal distribution, we think, from typical to atypical. So I don't tend to use the word normal. I don't like the word normal all that much. Typical and atypical seem to me much more helpful. And so generally speaking, what will happen is that if you are within the kind of normal range, you'll be fine, and you'll be able to, if you are a little bit ADHD, you'll be able to compensate. And so if you think about this as an imaginary impairment axis, your impairment will be virtually none for quite a lot of this variation, because you'll be able to cope, particularly if you're doing well, and if you're in a good, you're doing well from a mental health point perspective, if you've got good development in other respects, and you're well supported by the people around you, have positive relationships. There is a point at which you decompensate, however, and this is not something that you can necessarily see in population graphs, but there is a neat explanation for some of the features of ADHD. So there's a period, if you kind of turn up, if you had on a slider, on like a kind of graphic equalizer, the person's ADHD-ness, and you turned it up and up and up, you'd have a period where they would decompensate and they would start to really have to struggle. And then, of course, it would level off, because ultimately you can still walk and talk. And there's some point in here, I don't know if you can see the pointer that I'm putting on, but there's some point where as it is, let's have a look. Can anyone just let me know if they can see my pointer or not? That would be really helpful. There's some point at the point where, thank you, at the steep part of the curve where you would make a diagnosis. But I can't tell you where on that curve we should be making a diagnosis. Quite fairly clearly, if a child is here, you should. If a child is here, you probably shouldn't. But in between, there is a genuine grey area that I don't think you can ever really completely kind of magic away with criteria and all of the sort of clever stuff that we do. So yeah, so that's the impairment curve. If you just alter the environment, if you make relationships more positive, if you make the people around the child more able to meet their needs, if you deal with their mental health difficulties, if you find the fact that they've also got a language disorder and get them some speech and language therapy input, this is not a curve that is massively distant from the original curve. But if you look, so most children with an ADHD diagnosis will not be here, because here is a very tiny part of the population. Most children with ADHD diagnosis will be here. And in this population, even this very small change in the curve makes a massive difference to impairment. And so for me, the initial task of managing ADHD is to move this curve just a little bit, because you can have a really huge impact on impairment. And really, as doctors, it's impairment that we should be interested in, not symptoms. I think, somebody's still really ADHD, but is doing, but is doing brilliantly, then I'm extremely happy. I don't want to get rid of their ADHD. It's the last thing I want. But however, there is obviously something that can have some impact on where they are on the ADHD spectrum from a purely neurophysiological point of view, and that is medication. However, this curve is also important because it does demonstrate that if you're going to have an impact on, so let's say this child, I don't know if I've done this, I'll do this later actually. I'll come back to meds later and why it is that this curve is important in showing you where meds are and are not important, but I want to put that in later. What do we do about ADHD? So there's sort of 5 things, and usually I usually talk about 4 in clinic because I'm in explaining this condition, I'm already doing the first one. So psychoeducation is often put in the guidance, and everyone's like, yes, they should have some psychoeducation. Psychoeducation just means explaining stuff. It just means talking. It just means someone who knows about ADHD talking to someone who knows a bit less about ADHD and explaining, yes, this is to do with your this is to do with the ADHD. No, that's something else. Yes, this is how ADHD can be helped. Everything that we're doing when we're talking to a family is psychoeducation. So when people say, what's your psychoeducation program to me, I say, well, it's talking. That's what my psychoeducation program is. There is also that's a slightly facetious answer, but it is also important under the umbrella of psychoeducation to have things available to families. So in Lambeth, we're very lucky, we've got a webinar series, and we've got, even in lockdown, we've gone online, we've got regular parent group meetings, because saying something to someone once, particularly in the clinic room when everything is kind of bombarding them all the time, isn't necessarily that helpful. You've got to reiterate things, you've got to give it to them in video form, in written form, and we are working on that over time. Now, bear in mind, of course, a lot of the families, a lot of the parents have got undiagnosed ADHD, and so find it quite difficult to take in a huge amount of information that you might be giving them. So the first thing is brain health. And I've thought for a while about whether I want to use the term brain health, because it has a bit of a bad reputation as sort of a wellness thing. But actually, it's genuinely true. Whether your brain is in a good place, whether your brain is in a good place to cope with the fact that you have this disconnect between yourself and your brain is important, and there are genuinely things that are, there's no better phrase I can think of unless you can to express that relationship. So within that, it's also important to say there's a lot of stuff that people talk about with ADHD that doesn't really have any evidence. So it is important that children sleep, and of course we're all more and more aware of the impact of sleep on physical and mental health. ADHD is a really good example of something that both affects and is affected by poor sleep. Mental health is really important, and I think, as I've alluded, often it's missed in ADHD, particularly anxiety. So it's worth asking, if you think someone's got ADHD, to what extent some of their behaviours, particularly aggressive behaviours, can be mediated by anxiety. And so addressing the mental health aspects can be a really important first step. And then, of course, there's exercise. And we've had a lot of conversation in the last 3 months about exercise in kids with ADHD. It's been really, really, really tough because they've not got the exercise that they need. And then more or less, some of them are starting to kind of emerge now and to get a bit more exercise. But that does make it more difficult. It makes sleep more difficult. It makes everything more difficult if the kids don't get to exercise. One of the things that schools do, which infuriates me, is when the child misbehaves in class, take their break away. And then, of course, the child is therefore having to sit still for a long period of time, which is going to make their ADHD much worse. And then when everyone else comes back in from break, the child is going to be very much worse behaviourally. It doesn't make any sense at all, but there you are. And the other thing I've heard is that primary schools banning running in the banning running in the playgrounds, which again makes no sense, and I'm trying to look into that. Sam just asked a question. Thanks, Sam. Studies the impact of exercise on ADHD. Yes, it's actually a relatively limited field, and I think it's something that some people could certainly look into, and it would actually be a nice opportunity for someone to do so now. It's difficult because as an intervention, the intervention of physical therapy on children with ADHD, you often get very, very small study groups and quite messy data. The alternative is to look at how much exercise kids with ADHD get, and then look at their outcomes. But then, of course, you've got all sorts of confounders. So it's not difficult, so it is difficult to be absolutely clear about the link. But I think that there's enough, just about enough, to say that exercise, while not a treatment, is definitely something that is very much to encourage in ADHD. So Afaf, is that your name? Oh, Afaf, good, fine. Apart from the usual sleep hygiene and sometimes melatonin, well, so people say, oh, the usual sleep hygiene. Actually, putting sleep hygiene actually into place for kids with ADHD is more than a little bit difficult. So I think if you say so either families that say they have put sleep hygiene in and it's all going very well, and the child goes to sleep on their own in an appropriate place in a dark but not too dark room, which is quiet, and everyone, the child is trying their very hardest, and they are kind of just staring at the ceiling, and everyone doesn't know what to do. Well, at that point, I think it probably is reasonable to use melatonin, which is very effective and very good. I think the most common scenario is the family either say that they're doing all of this, and they're not really, which you can't do anything about, or they are not able to do it because there's something else. And there you have to go back to, well, what is it that also is a barrier? Is it that there is some kind of anxiety, separation anxiety? Is this where the child is being oppositional defiant, and you need to have a separate program of getting the child to the point of being willing to try, and that is, very much going back to the basics of gradual withdrawal. Parents reassuring the child and saying, you're fine, you're fine, you're fine, and then you can get back to, okay, he's in his room, he's just staring at the ceiling, at which point you can come in again. So I do. I thought it's a wonderful name. I've just never heard it before. And I work in Lambeth and all the names. So I think that's a good stepwise way of doing it. I think the majority, there are some people who've got it absolutely sorted and still not getting there with sleep, in which case melatonin is reasonable. But there's an awful lot in the middle where you've got to sort of work out what's going on and why it is that it's not working. And it's not because the strategies and the general principles of sleep don't work; they really do. Priscilla has asked about breakfast. Tips for breakfast. It's an interesting question. I mean, I think you have to go back to, is the child getting up on time? And if so, is it because they're not going to bed on time, in which case you've got to think about the sleep problem? Is it because the family as a whole are really sort of disorganized and chaotic, in which case do they need some kind of early help offer or kind of social care offer? Or is it because the child is literally unable to sit still for breakfast and basically needs to have their breakfast in banana form, or some sort of other portable form? It sort of depends what the question is, really. I'm going to go back to the slides, and thank you for all those questions. There's a pinging whenever anyone comes and goes, which is deeply frustrating, deeply distracting. Family support. So I put family support rather than parenting, because very often what happens when parents are given a diagnosis of ADHD is they're told, okay, well, what you need to do is go to a parenting course. And the message that can sometimes give to them is that your child has a problem because you have not parented them correctly. That is wrong and insulting, and leads to almost no engagement with intervention. So family support is much better, because it's also not just about parenting. You've got to make sure that the family are in a position to support this child. So if they have someone in the house who's violent, if there is a parent with severe mental health difficulties, if they have no food, if they are all in temporary accommodation with 3 other families and they don't actually have their own bedroom, they're sleeping on the front room, then any amount of sleep advice is not going to get there. And as I'm sure we're all kind of community adjacent paediatricians, we know this. But I think being explicit about the fact that we understand that poverty and disadvantage makes all of this stuff much more difficult, and that the family are in the situation that they're in a non-blaming way is really important. So sometimes it is as important to send them to a benefits advice line as it is to send them to a parenting class or to the housing department as it is to get them to do triple P. So that's a framing for the fact that it is definitely true that for dealing with oppositional defiant behaviours in the context of ADHD, parenting is really important. So a parenting class, which is a 8 to 12 week group-based class where parents will be professionally facilitated, but also working with other parents, and it's that discussion with other parents that's really key, is effective in increasing confidence and decreasing the incidence of defiant behaviours and aggressive behaviours. It is not a treatment for ADHD, however. It doesn't make the child less ADHD-y, if that's a word, but it does make things a lot easier. If you think about the curve that I showed you earlier, it definitely shifts the curve and makes things easier, even if it doesn't do a slightest change to the child's ADHD behaviours themselves. And so it's really, really important. The way I sell it to families is this. All parents with ADHD will have mates. All parents of children with ADHD will have mates who've also got children who are fine, and they don't have any problems. That's because most of us operate as parents at kind of 60% good level. And for most children, that's fine. But for ADHD kids, or actually lots of different categories of children, and you can use this argument, this little trick whenever you have a special needs kid. ADHD kids require a 90% good parenting, and actually the purpose of parenting intervention is to get the parent, perfectly good parent, from 60%, which is fine, to 90%. And that's why we think parenting is useful in this scenario. But it will not take their ADHD away, and it's really important that families remember that. 4 is school intervention. I'm really, really keen that we don't tell schools how to do their job. Because that's not our job. I think we should be very mindful of their own professional status, and the fact that there are within educational support services, but that we should leave it to the schools mainly to take the information that we have given them and manage them according to the special educational needs code of practice. So that brings in a few caveats to that. So if the school doesn't recognise that this is a special educational need and thinks that this is just a child who's, or a child who's lawful or a parent who's bad, then you do have to have tough conversations with schools. I think it's really important, particularly if you're working at a more strategic level and you're kind of leading locally, that you work together with other people in the borough or in the area that you're working to put together helpful advice for schools, which doesn't necessarily need to be medical advice. Ours comes from, I didn't actually write a single word of ours. It was written by the educational psychologists, clinical psychologists from CAMS and an OT. So making sure that kind of advice is out there is important from a strategic point of view, but we don't have to tell them what to do and how to do their job. If you really have problems, and often there are real problems between the family and the school, I'd suggest that you don't get involved except as a honest broker and a kind of friend to all. If the family needs specific intervention, there's every borough, every area, every local authority have an independent advice and support service for children with special educational needs. And all of these families can access this. Ours is legendary and amazing. I'm sure everyone's is pretty good, they are going to be the people who go into the meetings with families. Please don't get yourself sucked into a fight with school on either side. Right, we're coming towards the end. I always take a bit longer than I thought. So this is where I kind of put in the stuff about where meds sit. So if you're up here and you just give medication, it may have a little bit of an effect, but it won't have a huge effect on impairment unless you also change the environment. That's what I'm saying. So a lot of the kids we're considering for meds are around here because they're the more severe end of things. If you just do meds, you have a little bit of an effect. If you do meds and environmental modification, you can have, look, you go down a little bit and then you give a bit of meds and you're on the really steep part of the slope. So you can have a really big effect if you do both at once. And that's why we don't just do one, we do both. And I think it's worth doing the environmental stuff first, because you never know, it might be enough. Equally, that also explains why if you give meds at the lower end of things, and if you're kind of taking the US approach of giving meds to pretty much anyone who walks through the door, you're not going to have a big effect a lot of the time. I hope that makes sense. So your medications with, I'll answer that question in a minute, sounds a good question. Your medications will help with your core symptoms. It won't help with the anxiety, it won't help with the autism, it won't help with the poor self-esteem, the trauma. It will just help with the core symptoms, and the side effects are specific, are significant. So the last few minutes, I'm just going to quickly talk about some medications, and then Sam's question is a good closer, actually. Two important medications. So the number one, and still the number one after sort of 50 years of use, is methylphenidate. Effectively, methylphenidate is a quick rebalancing of whatever's going on. It gives a short-term boost to the supervisory role of the self, in a way. I say short term because the original formulation is a short term that lasts over 4 hours. The modified release versions tend to last between 6 and 8 hours, and we tend to just start a modified release. That would be Concerta, Equisim, and Medicanet XL. They're only licensed from 6 years, and before 6, I'm very wary of doing it, to be honest with you. I do sometimes, but try not to. And you can get initial agitation, which is particularly difficult if the child's also autistic. Appetite suppression is something that you get an awful lot of over time, and usually they'll skip or just graze for lunch, which, to go back to the kids who don't have breakfast, can be quite tricky. And so you have to really concentrate on those 2 meals either side of the day. And there are cardiac effects. It is inotropic, and if you have an underlying conduction defect, it can cause problems. The current guidance is that if you have a family abnormal cardiac exam, of course, or a family history of kind of early cardiac deficits or arrhythmias, then you get an ECG before you start. I've never had a problem cardiac-wise. So the second med I put in is melatonin, not one of the other ADHD medications, because it's super useful in this population. Just for sleep initiation, 30 minutes before bed. I should change this slide. It's a little older than I'd like. You give 2 milligrams to start with. If you sometimes increase, but more often it will work initially and then wear off because there's a kind of tolerance that builds up. So actually what you often need to do is then stop it and then restart it, often at a lower dose, although sometimes back at milligrams. You just have to take it and then stop it and then take it. It is currently mostly unlicensed, although there is now a licensed, very expensive form of it. I don't think anyone really cares anymore about the unlicensed nature of it. GPs are starting it all over the place. It's very, very safe, and it may actually improve daytime behaviour, particularly make people more tolerant. And 2 other medications I need to mention. So atomoxetine, I almost think of as like the herbal medicine of ADHD, and that's not to say it's because herbal medicine is mainly ineffective, but atomoxetine is much gentler, it's much more slow acting, it doesn't really tend to cause the agitation, or this. Sometimes also the methylphenidate can cause some problems with sleep. It doesn't do that. It's a lovely drug, if only it would work better. And there's just too many kids who just don't find it works for it to be first line. But if you're having any problems with side effects, I'm quite quick to switch to atomoxetine. Apart from anything else, it buys you a bit of time while other things are being sorted out, because you have to say to the family, this may not have its maximum effect for about 2 or 3 months. So it's kind of a nice little trick you can use sometimes. Just give you some time with everything to calm down, because if you've given medication and things have not worked out, that can be a very emotional time for everyone. The final one I want to mention, because it's first line in adults actually, and there are people who are enthusiastic about it, is lisdexamfetamine. It's very much like methylphenidate. It seems to me to be like methylphenidate supercharged, both in the sense that it can be effective when methylphenidate isn't, but also in the fact that the side effects, when they happen, can be quite striking. It's fine, it's great, it's an option, but I still think it's number 3 so far. I'm not going to give you details on prescription rates and doses, because that's why the BNFC exists. So what is the progression of ADHD, which is the slide I should have at the end. So historically, they've done quite badly. If you look at the Scandinavian registry studies, they do quite badly. They have an increased risk of relationship breakdown. I should say we, really, because I do have ADHD. Relationship breakdown, criminality, lower rates of employment, lower rates of academic success, all sorts of things. Everything that could be bad is worse. However, actually it looks like treatment and it looks like medication, although there's some caveats about that. It looks like treatment can really very substantially decrease those negative impacts. In terms of how you progress, in the sense of how your brain evolves, most people, so if you can sort of look at, well, let's look at diagnostic criteria. I'm not sure that that's as helpful, because some things get better, basically. So your hyperactivity and impulsivity tend to get better. The disorganization, emotional control, and attention don't necessarily get better at as much. And that's fine. So a proportion of kids as adults will come out of the diagnostic range, but they'll still be different to their typical peers. They may not be diagnosably different, and they may actually find ways around things. So you will choose a niche that suits you. You will get a phone, which will help you to remember that you're meant to be doing things. So it's not simply a question of the brain changing, it's also the context changing. And most importantly, and the key really, is that we need to deliver young people into adulthood with their mental health intact. And I think if we can do that, then actually they do very well, medication or not medication, because they can then start to harness their strengths against the background of basically having been encouraged and feeling that they are able to do things. So I think I hope that's an answer to your question, Sam. People are drifting away, got other stuff to do. There's 2 websites up here, one of which is more finished than the other. One is our local support website for ADHD kids, Arcs Lambeth, and the other is a new charity that I'm trustee of, and we're setting up. So it's just something to bear in mind. We're hoping to be a good and reliable source of ADHD information. So it's been a bit of a whirlwind tour. An hour is not much for something I spend most of my time on. Has anyone got any questions? I don't have to rush away. If people do, then that's absolutely fine. Thank you. I'm going to hang out just for a bit in case anyone has any questions. In case anyone's still here, yes. I think fearfulness, I don't think they're more fearful than other children, although they may be more fearful because they've been inappropriately managed in the past. I think that their emotions are very much more on the surface, and so that they will express their emotions in a much more overt and often, to other people's minds, over the top kind of way. This is a question from Afaf about whether the children are more scared than other children. I do come across it, but I think it's just an amplification of normal childhood fears that often have been either kind of dismissed by the adults because the children are so over the top with it, they're like, don't be ridiculous, or they are kind of almost encouraged by the adults. And you know, there are a proportion of of carers who sort of, you know, in some way want their child to have a problem. That's very rare. More often they've just been poo-pooed and then it's just got worse and worse. So yeah, I mean, I think it's part of the fact that we need to really think about mental health as a comorbidity in ADHD, as in what specifically anxiety and depression as a comorbidity, particularly anxiety. Katie, are you asking how having ADHD changes how I approach things? I don't really understand the question, sorry. Do you want to unmute?
Sorry. I was just wondering, because you said you quite often it runs in families, and I was just wondering if they're able to implement some of that environmental changes, or if they find it more challenging, or
it's really difficult often, and it's often the control of their own emotions that's really challenging, and the consistency that's really challenging. On the other hand, they often, if you can explain, particularly if they've kind of got a diagnosis or at least a self-diagnosis themselves, they often are very empathic towards the child and understand in a kind of instinctive way where the behaviours often come from, and that can be really helpful. So they often end up with a quite different parenting style, but one that does seem to work. I mean, I said, quite honestly, I think we could probably send about a third to a half of the family, of the parents, to an adult ADHD clinic, at least for an assessment.
I was wondering, I've encountered some parents who say, in terms of coping strategies, one of the things they do is, you were talking about exercise, exercising the children more, particularly in the morning, and they find that helps them concentrate more sort of later in the day. Do you think does that have any evidence base or not really?
I think exercising in the morning is particularly helpful, and again, the evidence base for a specific intervention of morning exercise is a bit small, but that's because there just isn't much out there. I think, yes, I think it's really helpful. It does tend to put them in a better place in the short term. The other reason why morning exercise is particularly helpful is that it's very good for resetting your circadian clock, so that you will therefore sleep better at night. So the sleep clinic often emphasise getting early morning bright light and sunlight, and so it is very helpful. It's very challenging to get teenagers to do it though.
Yeah, I can imagine. Thank you very much.
Yeah, right.
Can I ask one more question?
Sure.
Hi, it's Afaf here, by the way. I do exist.
Sorry, I apologise. I feel a bit rude, actually. Actually, I've come across it before. It's brilliant. I love coming across it. I love coming across a new name. It's one of my favourite things. Go on, carry on.
Wonderful. I just wanted to ask, do ADHD children have kind of higher incidence of having what we call accidents, whether it's stools or urine or nocturnal enuresis?
I always meant to look this up. I don't know that we've ever had a proper look at it, because I think if you look at SEN children overall, yes, of course they would do. And I don't know if anyone's really teased out from the ADHD cohort to what extent it's related to comorbid autistic spectrum disorder or anxiety. So I think, yes, if you look at the population as a whole, it almost certainly will be, but I'm not completely convinced that we have evidence that it's to do with their ADHD itself. Having said which, I do have quite a number of kids who are so distractible that particularly if they're on their PlayStation, they'll often wet themselves because they just have managed to distract themselves from how much they need a wee way. And that seems to be quite a specific ADHD thing, although it may be that other people have seen it elsewhere.
Yeah, I've actually come across quite a few children like this as well. They're just too distracted to do something or watch TV that they actually end up having accidents.
Yeah. So I think it might be worth a case series, I guess, because there are lots of kids, I think, who wet themselves and have poo problems with ADHD, and it's just separating out those who have got that due to comorbid problems and those who have got this particular phenomenon, which is really fascinating. And, you know, we don't know, we know very little about the relationship with their own bodily sensations. We talk about sensory modulation, sensory integration in autism all the time, but it's also a problem in ADHD. And so, you know, are they understanding what their bodies are telling them? Are they kind of, you know, are they feeling like typical children, what a full bladder feels like or what a full gut feels like? We don't really know.
Yeah, that's actually really fascinating. Thank you very much. Yeah, very.
I want to say thank you so much for the talk. I thought it was really, really helpful. I just want one more question. I'm really interested by what you were saying about the sensory aspects of it, in particular relating to concentration, especially around what you were saying about ability to concentrate on games where there's actually higher amount of stimulation. And I've sort of encountered that across a couple of children, I bet, who say sort of that counterintuitively they're actually more able to concentrate, say, on studying when they actually have more inputs, sort of a variety of a stimulus, variety of sensory inputs, which would distract.
Absolutely.
You know, perhaps other people would find distracting, which sort of runs counterintuitive to, I think, a lot of educational narrative where it's, you know, switch off the distractions and study. Is that something you find across your work?
Absolutely, it's very, very important. And I think, you know, so for ADHD teenagers, they almost always work with music on, because silence is very, very difficult, because they will fill the silence with whatever. And if the music almost kind of keeps that part of their brain busy that needs to be stimulated, well, the rest of their brain gets on with what they need to do. And the other thing is fidgeting. Fidgeting is a self-distraction strategy, and you'll find that the child who is allowed to fidget will actually concentrate better on what you're saying than the child who is concentrating on not fidgeting, if that makes sense. So if the child is absolutely not allowed to move, very often teachers will find that they will not be taking anything in, whereas if they are actually doing their fidgeting and fiddling, and actually we will do it a little bit, just to keep their brain ticking over, then they find that they take it in very much more. And so one of the things that teachers often say is, it doesn't look like he's paying attention, but then he reproduces what I've said absolutely word for word. And so it's challenging for schools because they have this whole thing about listening behaviour. Let's show me some listening behaviour on the assumption that that is how children are listen best. But actually, for these children, that assumption is not true. And so you sometimes have to have conversations with schools about that.
That's really helpful. And as someone who was told off a lot for fidgeting, I appreciate it. Thanks very much for the talk.
It's really interesting with regards to.
Like it.
Sorry, can I ask one more comment? So, with regards to the having their brain busy to be able to focus on what they need to do, would that also be true for sleep? So, if they had some sort of kind of one of those shiny stars to look at, or one of those kind of mobiles or something that moves around that they can focus on to actually distract them to sit still enough in the bed to go to sleep, obviously in a dark room. Have you ever seen that to actually work?
Yeah, I think that's something that can be very tricky when you're trying to get them to do kind of sleep hygiene, because often sleep hygiene is about totally removing all stimuli from the from the room, and that can be very, very difficult for the kids. And so I think that's right. I think perhaps we should have talked a bit more about that, is that sometimes they need something that is not stimulating enough to keep them awake, so not a phone, but it is going to keep their brain ticking over to an extent. And yes, for young children, something visual but not kind of blue lighty, not kind of too stimulating, is a good idea. For older children and adolescents, it's often something audio. And I know it's very unfashionable, want you to dig out a CD player out of the cupboard, or have a Bluetooth speaker with the phone on the other side of the door. But actually something which is audio and not visual will sometimes just keep them not bored enough that they have to come out, but stimulated enough that but not so stimulated that they stay awake. It's about finding the kind of the right level of stimulation for them to be able to cope.
That's really helpful. Thank you so much. It was a lovely, lovely talk. Thanks.
No worries, no worries. Thank you, guys. I think we're done. I think we're done. All right, I'm going to stop the recording, I think.